All right. Thanks, Eric. He was actually my chief resident when I was a resident, so it's kind of nice seeing him here again. So thank you all for having me here today. I'm going to give a talk on virtual care and thrombosis management. It's very topical as it's kind of a new thing for all of us. So these are my disclosures, which I don't personally have any. There's some to my clinic. And then disclosure of financial support at Thrombosis Canada and their mitigating strategies. So I do understand I'm kind of standing in between you and lunch, so I try to make this exciting, hopefully make this have usable tips that you can incorporate into your practice. So first, I want to kind of define what are the trends in virtual care. I think the most important thing to take away from this talk is learn how to select which patients need to be seen in person and which ones can be seen virtually, and then maybe some tips and tricks for your practice in virtual care. Okay, so here's our first case that I'm going to talk about. So we have a middle-aged patient who was found to have a left internal jugular venous thrombosis during a routine imaging scan. They had no symptoms to kind of present, no headaches, no plethora, no swelling of note. Their only risk factor was some recent air travel, and there's no access to any nearby clinics. And so this is the scan here, and in the top picture here, the TH is the thrombus, and this is the internal jugular vein. And so there's no flow going through that area of the thrombus. And so I'm just going to do a poll in the audience to see kind of what you guys would do. So these are the options. And so I'm going to read them out and maybe have a show of hands. So A, you would prescribe a DOAC and arrange follow-up with a thrombosis doctor. Okay, we got one. Okay, 1, 2. Okay. B, prescribe a low molecular weight heparin with a plan to transition to DOAC after further investigations. Okay, maybe a few. Serial ultrasound imaging to monitor for clot progression. Okay, I got a few. And then you'll send the patient to the emergency department for more tests. Okay, so ABC are reasonable options. D is not, because this case happened on the International Space Station. Okay, so this was a case that was published and about an astronaut. And so I'll kind of go through the timeline. But this is an example of virtual care. Even on the space station, they're giving thrombosis care to our astronauts. And so this case was actually published in January 2020, just before the pandemic. And this is the timeline. They're doing a research study on vascular flow. And so all the astronauts had to image various vessels. And on one of them, they found a blood clot. And so they didn't know what to do. So they did a virtual visit with some of the hematologists in the States. And they decided, because of their limited supply, they only actually had enoxaparin. They started the patient on enoxaparin. So they actually started off at 1.5 milligrams per kilogram at first. And then their supply got low, so they had to step them down to a milligram per kilogram around the 1 month mark. At the 6-week mark, they sent a supply spacecraft up with some DOAC. And they also sent some protamine and some PCC just in case. And so the patient was switched over to apixaban and completed a 3-month course. At the 3-month mark, they did another ultrasound, which again showed the clot. And so he was actually stepped down to a bit of a prophylaxis dose of 2.5 milligrams. And then 4 days before re-entry, they thought he might get banged up. So they actually held the blood thinners, let the patient enter Earth, and then did some serial ultrasound. And, the case is interesting because, day 1 back on Earth, he actually still had some clot thrombus. But by day 10, it actually dissolved completely. So there clearly is some effect of space on blood flow, right? But this is an example of virtual care, right? Like there's no radiologist, no emergency departments, barely a pharmacy, yet he got proper care. And so what is virtual care? So CMA and Canada Health Infoway has this definition that they kind of published recently. So any interaction between patients and members of their circle of care occurring remotely using any forms of technology to facilitate and maximize the quality and effectiveness of patient care. And so on this survey, which they looked at 2,000 physicians in Canada, they found that most of you guys are practicing some type of virtual care. 94% of physicians provided virtual care. About 50% have provided some type of video conferencing, and most of them are for patients that you do know. What do patients think of this? And largely, they love this. I've had many patients tell me, "I'm never seeing you again in person. This is just too easy. This is too good." And so 90% of people find this type of care very satisfying. They find it's private. They kind of understand the technology. There's some stuff that's still working on, which is, including family members and trying to help anxiety around emerging cases. But by and large, a lot of virtual care is very safe. And so here's kind of a poll of the audience. And this is kind of choose your own emoji, right? So what are your thoughts on virtual care? So A, I'll do it because I'm forced to, but I really don't like it. Okay. B, I think in-person visits are still better. That's kind of ambivalent. Yeah. Number 3, I guess I'll go along with it. It's not too bad. Okay. 4, this is sometimes fun, sometimes it's weird. Yeah, that's kind of me. Sometimes it's fun, sometimes weird. And then number 5 is I drank the Kool-Aid. This is great. Okay, so we have some Kool-Aid drinkers in the audience here. Okay, so the visit types that people have largely are telephone. About 75% of these visits are telephone, and 15% are Zoom or kind of video visit, Ontario Health, telehealth. And then there's email and chat and other asynchronous forms of communication. For the most part, a lot of them are for very routine things, prescription renewals, new prescriptions, side effects from medications, some counseling, but about a quarter are for organizing even more complex things, such as referral to specialists, ordering diagnostic tests, finding a diagnosis. And so what are the benefits for patients? So I practice out in Edmonton, and we have a catchment area of about 1 million people. And after the pandemic and virtual care was here, our catchment area went up by, probably 500,000 people. So now we're servicing anywhere from central Alberta northwards. And so patients really love this because they have access to specialists now. They don't have to drive 5 hours to see someone. They don't have to, take a lot of time off to come see you. There's also a lot of patients that we now have access to, people in nursing homes, people who aren't as mobile that now can see doctors very easily. There's also the time aspect for patients, time taking off work, the travel time, and also time going to emergency visits. And so we're trying to redirect a lot of patients to see us first rather than going to the emergency department. Cost is actually a big thing between parking, missed work, arranging childcare. They say the average patient loses about $100 per routine visit, actually. And of course, this is the thing that really drove things was exposure to COVID-19. So we know all these benefits, but COVID-19 really helped accelerate all these things. So there's other, improvement things for patients, including patient outcomes. So one group in Germany kind of studied telemedicine for improving, quality in patients who are anticoagulated. A lot of this was in patients with on warfarin, but they compared basically 360 patients in a routine medical care versus 250 in telemedicine first type of care. They had a specialized team of pharmacists and an algorithm and teams to kind of help see these patients. It was a prospective multi-center cohort study, and they looked at clinically relevant endpoints such as bleeding, thromboembolic events, and hospitalization. And by large, they found that there's a very clear benefit for a telemedicine-based focused type of anticoagulation care. So you'll see in the primary outcome for mortality, bleeding, and thromboembolic events, the hazard ratio improvements very good. And so this is just one example where telemedicine is really driving quality too. So I think what's in it for us too, right? Like we have to get something out of this. And so I think about all the things that are good for us. We kind of decrease our overhead costs, whether that's staffing, whether that's getting things like PPE, just making your clinic more efficient, slimming down things. I also like working from home. I used to envy all my friends in tech when they were working from home, and then all of a sudden I was doing it. And so I got to experience a bit of that too. And so there's definitely a lifestyle to it in between patients. I'm doing some childcare, I'm preparing dinner. It's really nice sometimes to help out at home when I can. And it's comfortable, you only have to look professional from the waist up, right? And so it's not bad thing. And this is my setup here. And it's actually in my kids' playroom. So right behind me, my kids can play too. And we kind of share the space. Okay. And so this kind of the takeaway from this slide is to always think about the right patient for the right encounter. Virtual medicine works, but only for the right situation. And so if one side is in-person visits and one side's virtual visits, everything's really a spectrum. And these are kind of the things we're going to go through. I often look at geography, how far are the patients away? I look at whether their health literacy is good, whether they have language barriers. Some, newcomers to Canada where English is not their first language might not be great for a virtual visit. I look at socioeconomic and physical barriers, things like cost, wheelchair accessibility. I look at case complexity. Simple routine cases or prescription issues can be done virtually. Patients who are very complex, probably better in person. I think about new consults, meeting people for the first time versus whether this is just a follow-up. And I think about their age and their comfort with technology. Surprisingly, most patients will have some type of mobile technology, and most can use telephone or even simple apps on their phone. And I always think about patient preference. I always ask them, if you want to do this in person or virtual, it's up to you. And then we kind of go through it too. So there's a bit of a pre-screening criteria, often prior to the visit. So kind of poll number 3, what kind of percentage of patients do you think you'll be seeing kind of moving forward in the future? Will it be A, none? I'm only doing in-person visits in the future. Okay, not a lot. B, about 30% virtual, 70% in person. Okay. C, 50-50, half in virtual. Okay, good. D, kind of a virtual first strategy, 70%. Okay, I see the Kool-Aid drinkers are back. And then the 100%, I'm never wearing work clothes again, right? Okay. So I think, most of us fall in the spectrum and kind of recognize the value in virtual care, and we'll kind of incorporate into our practice in the future. So now this is kind of just tips and tricks, things I've acquired, things I've been reading about how to make your virtual care practice better. So we'll start with a typical case. A 50-year-old female has symptoms of leg swelling. She went to the emergency department and was found to have a DVT. So then she gets referred to you're back to your family doctor or as a specialist for follow-up or consultation. And so what can you do in this situation? So first off, I always like to think about this new term, website manners, right? It's no longer bedside manners. It's about how you do things on the web. And so you got to plan ahead. So make sure you have the right technical equipment, good internet speeds, headphones, good webcam, encrypted emails, all the tools at your disposal to really make it a good experience. I also think about getting water, coffee, refreshments. There's no need to, at work you're wearing a mask all day, right? You can't sip coffee, and at home it's really relaxing. I like to think about setting the stage, right? Making sure your place is tidy, making sure you look, again, professional from waist up, cleaning up, workspace before you start. I always start every visit with what's called like a virtual handshake. This is where I introduce myself. I make sure there's other people. If there's other people on the call, sometimes they're conference calling or on speakerphone, I kind of inquire who's on the line. I also make sure they're not doing something else. Oftentimes patients are working now. And so making sure that they have time off in a private space. And then the big offender I have a few patients who are driving. And so if they're driving, you just have to tell them you have to call them back because you don't want to cause an accident. So making sure it's appropriate and making sure the settings in the right place. Location, there's a bit of jurisdiction too, making sure your patients are in your province where you're licensed to practice. And then I think about virtual manners. There's bedside manners and there's virtual manners. And so this is things about building connection. And so you got to make sure you don't get too distracted. We have phones, we have screens, your email might be up. So oftentimes when I'm seeing patients, I actually kind of like to stand up and pace around just so I can focus and concentrate on them. Otherwise, it can be actually quite distracting. Okay. So this is history taking. So listen to your patient. He is telling you the diagnosis. And that's from William Osler. This is a picture of the doctor, And so a lot of what we do is mainly just history taking. And so doubly so in virtual medicine, we have to be extra detailed. We often miss a lot of the visual cues, patients' emotions that kind of illustrate the severity. So you have to ask all the questions, but in more details. And so for in DVT, it's making sure you're going through all the symptoms, the swelling, the pain, the redness, the skin changes. I often try to make it a memorable history taking. I ask them all sorts about their hobbies, all things about who they are as a person, because we have to build that connection, which is so important that gets lost. I oftentimes, when I'm taking history, I do real-time checking. So they kind of give me a timeline and I'm correlating with some of the tests that I can see in the EMR. And then oftentimes just making sure you're not missing anything, asking for constitutional symptoms. You no longer can see if a patient looks cachexic. You got to make sure you're asking these things to make sure you're not missing it. Okay. So next we have the physical exam. Which, for the most part, there's not a lot of maneuvers for the physical exam. So you do save a few minutes here and there. But the things I always make sure to do is if there's something that they say, hey, doc, you need to look at this, I tell them, send me that picture. A picture really is worth 1,000 words. And if you have some way of getting a encrypted picture over to you, you can attach it to the chart and you can actually monitor progression through time. If there's a lot of swelling, edema, skin changes, that's been very helpful. The one physical exam maneuver I do without fail is I always ask for a height and a weight. This lets me calculate basically a BMI, which is a risk factor, and also lets me do things like dosing of low molecular weight heparin. And then there's some patient-assisted maneuvers. I think there's an area of big research that's still coming up, but I sometimes ask them if they have a measuring tape to measure the calf circumference. Sometimes I ask them to do pitting edema to see how far it goes up. These things can be helpful. Okay. So kind of, we then do the discussion around it, and kind of when we get to the conclusion of our visits, these are the things we really need to make sure. We have to make sure there's good follow-up. So this is making sure the prescriptions are faxed or called in. I often use email as a way of follow-up with a lot of patients. I send them instructions, I send them lab recs, I send them imaging recs, and most patients know how to do this intuitively. Making sure you book follow-up. Oftentimes patients used to, on the way out, book their next follow-up. And so having a system in place to make sure patients aren't lost to follow-up. I often ask for local help. So depending on where they are, they might have different resources. They might have some pharmacies that can do some of the teaching with low molecular weight heparins. And so we have certain pharmacies we refer to. Often recruit family members to help monitor things or arrange tests for patients. And oftentimes you ask to see what other resources they have, whether that's a more local anticoagulation management clinic, or whether there's other types of remote services that we can do. And always kind of manage expectations. I think this is kind of new for patients. It's also new for us. And so a lot of it is making sure that they know what to expect and we also know what to expect. And so I often offer, a chance to see me in person if ever needed, and also get them connected with our online portal so they can see all their own results. Okay. So what does the future hold for us, right? I think there's a lot of good things happening in the future. I think technology is always getting better, and there's oftentimes new things that are coming up. And so in this new hybrid world, we might see virtual visits include things like augmented reality, virtual reality, right? I think about remote ultrasound imaging, like in the space station, where patients don't have to come in to get things done. They can maybe get it done more remotely. I think about how we can streamline visits better in the future. And this is going to be an important part, recruiting an interdisciplinary health team. So having nurses and pharmacists also be part of the process. I think about questionnaires that we can send patients ahead of time to kind of really get rid of those pain points, right? Like things like medication reconciliation, doing things like calculation of scores, right? The Volta or Hazlitt scores can save you a lot of time. And then also think about, I have patients too often give me the whole history. They email me all their symptoms, and I just copy that into my chart as part of my documentation. So that streamlines and helps actually save a lot of time. I think about how we can do education and research in this area. It's a very kind of new place, and we have trainees all the time, and it's not a great experience right now for them, but we have to make it better because it is going to be our practice, and they'll have to do it one day too. And most importantly, I think about building connection. How can we make this part of our care that's just as meaningful to patients? I think our interactions with patients really help build that relationship, which is so pivotal and meaningful, and we have to make sure we're not missing that. And so that's still the big unknown. So I'd like to thank my kids who kind of enjoy my presence at home, and my wife for looking after them this weekend. This is where I work. I'm kind of optimistic about virtual care. I think it is an exciting area. I think there's a lot to come. The best is yet to come, and patients really enjoy it. So I'd like to pass this time for any questions or any comments and things I can help with.
I invite you all to approach the microphones if you have questions. I'll start with a question from online. Could you comment, Tim, or what's your opinion on patients or family members recording virtual encounters? Is this something that you bring up preemptively with them?
I do, and I think it's it's similar with inpatient encounters too, right? It's about getting consent and making sure everyone is aware of it's happening. I think if it's done secretly, that's not great. I think, it's being open, right? And oftentimes patients will tell you if they are recording, right? Just to take notes. Sometimes what I will actually tell a lot of patients is, let's do the visit first. And if this is, a message that's going to be disseminated between your family members, we'll do a portion where I can record a portion in layperson terminology, and so that you can disseminate that. And I find they really appreciate that, because that's what they really want, is a way to document and remember what was said, right? And so sometimes I just say, okay, we'll do that at the end, and we'll record a segment that you can listen to and specific instructions. Otherwise, sometimes it gets a bit overly technical. So I'm not against it. I think it just has to be done properly.
Then a question from Leo.
Thank you, Dr. Chen. Dr. Chen, can you make comments on, you've mentioned about self-reporting some measurement on reliability, reproducibility, and comparison with quote unquote gold standards for us to evaluate obtaining clinical/research data virtually, please? Thank you.
Yeah, that's a great question, right? Like, how do we trust the information we're getting? And I find pictures are very objective, which I really like. And then sometimes, you know, if you want, you can get them to wrap it around and see. I think the good part is oftentimes they're the one repeating the maneuver. And so there is the same operator that does have it. But I think it's a difficult question to solve, right? Is how can we trust what we're being told versus, you know, using our own objective measurements? So I'm not sure if there's a great answer to that other than, you know, making it reproducible, having the same steps. And it's going to be education to a lot of patients, right? To understand how these questionnaires work, right? But that's a great question. And I'm not sure I have the answer to that.
Thanks very much, Tim.
All right.